So, hello everyone. I'm Dr. Omkar Sangita Diliprao Sonomi from Team AFMG, and today I am here with the FMG June 2022 session recall questions. Definitely, I know that you must be exhausted after a few months of hard work that we have done in the last few months. So, definitely, it's the time to relax, chill down a bit, and don't worry about the results at all. Okay, whatever you have worked for, definitely it will yield results finally. Okay, so good luck for your results. Definitely, I'm pretty sure that you all are going to make it. Okay, now don't be worried about the recall so much. Okay, the most important thing is while I'm doing a recall video, I'll be doing subsequent videos as well. Either I'll be recording those videos or I'll be coming live from the FMG YouTube channel. Okay, so don't worry about that. I'll be trying to get as much as questions possible in the recall. So now it's the time to relax and just try to recall how whatever questions you get. Okay, but just don't get behind everything now. So I would like to first of all extend my heartfelt request. Now, first of all, I would like to extend my heartfelt thanks to all my students who have been there associated with me in the last 4 to 5 days for the recalls questions. I need to specially mention few names, that is Mahipal, Himanshu, Virendra, Priyanka, Nishant, Himvardhan, Lovely, Anto, Kishore, and all others who I forgot to mention. Thank you so very much for the recall because that will definitely help you as well as the subsequent FMG aspirants who are coming for the next upcoming sessions of FMG. And definitely the topics would remain similar. So all those who are attending for the upcoming session, let me tell you that definitely the topics will remain similar. Okay, the topics would be similar almost. So be sure that you make sure that you actually go through these all PYQ session topics as well. That is more important. Okay, so let me start with the first question, guys. So talking about the first question over here that we have, and most of the questions, I'm really glad that those were from the AFMG notes. Definitely, most of the faculties have covered it. We have covered it in the TND test and discussion session. We have subsequently covered it in the chanting sessions, even in the QRS session. So most of the questions have been repeated multiple number of times, and I'm glad that most of you were able to answer those questions. Right? Some of the questions were definitely googly, and that definitely most of the people were not able to correct it, answer it correctly. So don't worry about those questions. But the important ones were the ones which we have already discussed in the FMG class or maybe in the subsequent chanting or QRS sessions. Okay, I hope none of you have marked those wrong at least. So starting with the first question, guys, the first question says a patient sustained a fracture due to fall on an outstretched hand. Okay, fall on an outstretched hand means the injury mechanism of injury is known as push. Okay, the mechanism of injury is actually known as push. And the below given cast was applied in champagne holding position. Which of the type of fracture the patient has sustained? So definitely we have discussed about the mechanism of injury of push, right? So push is the mechanism of injury, fall on an outstretched hand, and we'll discuss three types of fractures. If it is a child with push type of injury, then definitely he will sustain usually a supracondylar fracture of humerus. If it is a child, he will sustain a supracondylar fracture of humerus. If it is an adolescent or an adult, okay, adolescent or adult, after a push injury, he will sustain a scaphoid fracture. He will sustain a scaphoid fracture. Whereas if the patient is an elderly and after a push injury, the patient will more likely sustain a Colles fracture, right? The patient will more likely sustain a Colles fracture. So here they did not mention. Some people are saying they mentioned the age. Some people are saying they did not mention the age. Okay, no worries. Whether they have mentioned the age or not mentioned the age, they have given enough hints in the question. Okay, in the next lines, a patient sustained a fracture due to push injury, and the below given cast was applied. What is this cast? As we have already discussed in the classes as well, this cast, it looks like the patient is holding a glass or the patient is holding a champagne. So the below given cast was applied in the champagne holding position or a glass holding position, and that we have already discussed. Okay, which type of fracture the patient has sustained. So definitely, as we know, champagne holding or glass holding cast is usually applied for option C, scaphoid fracture. They are applied for scaphoid fracture. As we know, scaphoid fracture is the most common carpal bone to fracture, right? That is the most common carpal bone to fracture, and it is the second most common site It is the second most common site for avascular necrosis. Okay, most common site of AVN is definitely the head of femur, followed by the proximal part of scaphoid due to the fracture at the waist of the scaphoid. And the cast which is applied is the glass holding position or the champagne holding position cast. Okay, hand shaking position cast, as we know, definitely that is usually applied in cases of Colles fracture. No issues with that. So please remember, these are the important things that you need to remember. Okay. Apart from this, then if I move further, the question number 2 says the below given image is more likely associated with which among the following condition. I hope this was the easiest one, right? Dr. Ankit would have discussed in his sessions as well. Apart from that, we have also discussed in our T&D session of psychiatry, right? So such a picture which is showing that a patient is continuously washing the hand and there is written "wash me" on the hands. What does it signify? It signifies that the patient is having recurrent and the patient is having recurrent and repetitive thoughts about contamination, right? So these are what are called as obsessions. Okay, so recurrent thoughts about contamination are what are called as obsessions. And to overcome the anxiety due to these obsessions, the patient is likely washing his hands multiple times. Okay, those are his compulsions. So this is nothing but an obsessive compulsive disorder. Okay, so this is a classical example of OCD. And as we have discussed in classroom, the most common type of obsessive compulsive disorder is obsessions of contamination with compulsions of hand washing. That what the picture signifies in this image. Okay, no issues with this. So please remember, this was the most common type of obsessive compulsive disorder. I was not able to get recall for the other options. If you have the recall for the subsequent options, please let me know as well. Okay, so convergent disorder, as we have discussed in class, it is nothing related to obsessions or contamination, obsessions or compulsions. It is rather a disorder of identity, and the patient will have a classical fundamental indifference. Okay, over there. If this was the option, then it can be easily ruled out. It is definitely identity disorder, and there the patient is having lack of concern or labile indifference. That also we have discussed in classroom. Okay, please let me know the other options if you have. A classical question, most of you were amused with this. A female patient was operated and the following structure was obtained, where the patient shall be referred after surgery. So here you can see there is almost a mass of hair, okay, almost a tuft of hair, which has been obtained after the surgery of the stomach, and the tuft of hair has almost taken the shape of the stomach and the pylorus that you can see over here. So definitely this is nothing but a trichobezoar. This is nothing but a trichobezoar. And as we know, trichobezoar is definitely eating of hairs usually, and it is commonly associated with psychiatric females, the females suffering from psychiatric disorders. And as we know, a condition which we have discussed in dermatology also and psychiatry as well, a patient having an irresistible desire to pull her hairs. That is what is trichotillomania. That is what is trichotillomania. And after pulling her hair, the patient likes to eat the hair. Okay, that is what leads to the trichobezoar in the patient. So after the patient has been after the patient has been operated for trichobezoar, now the patient has to be referred to a psychiatrist for further advice or further opinion. Okay, so that is a psychiatric consultation is required after this. Okay, definitely not neurologist, not dermatologist is required. Okay, important thing. Definitely the patient will first of all might be the patient's attendants or the relatives will take her to dermatologist at first due to alopecia, which is seen, that is trichotillomania. But subsequently, when she's eating the hairs, definitely when the trichobezoar was removed, now there is a important thing that the patient should be referred to a psychiatrist for further consultation. No issues with this. This was the easier question, I feel so, right? Phytobezoars, as we know, phytobezoars are due to injection of vegetative material like plants, vagara. Okay, lactatobezoar is due to injection of milk and dairy products usually. Okay. Next important thing is question number 4. You suddenly see a guy collapse. You check for his vitals and started CPR, cardiopulmonary resuscitation. Soon the advanced cardiac life support arrived, that is ACLS, arrived at the scene. So what would you ideally do? So what is your next step? As I have always told you, हमने बहुत बार discuss कर लिया है कि next step is one of their favorite questions nowadays. In any of the questions, they will like to ask you next step. CPR we have discussed in details in the integrated session for cardiovascular system of medicine, right? So here you see a guy collapse, you check for vitals, maybe the breathing and pulse was absent. Therefore, you started CPR in the patient and you also activated the emergency response, due to which the advanced cardiac life support has arrived at the scene. Now, what is the next step in this process? So option A says hand over and leave. Definitely, if you are a responsible physician, leaving the scene is definitely not an thing to do. So handover and leave is definitely ruled out easily. Option B says continue CPR while defibrillator is used. Now there was a bit confusion. I would like you guys to just correct me in the chat box, or tell me all the corrections whatever there are in my Telegram handle. Okay, so important thing was, some people are saying that continue CPR while defibrillator was used. This was the option. Some people are saying that continue CPR while paddles were applied. So if the option was while paddles are applied, then that would be a right option. Okay, while paddles are applied, definitely you need to continue the CPR. But while defibrillator is used, after the paddles are applied, once you start using the defibrillator, you need to clear. Okay, you need to clear off the patient. You don't need to touch the patient. Okay, so that is what is required. So definitely continue CPR while defibrillator is used. If this was the option, this is a wrong statement. While paddles are applied, then that would be a correct statement. Option C says stop CPR while defibrillator is used. As I told you, you need to clear off the patient, okay, while shock is being given, or while defibrillator is being used on the patient. So definitely option C is a true statement. Option D says continue 5 rounds of CPR and then use defibrillator. Usually, as soon as the defibrillator arrives and the patient is and we apply the paddles as soon as possible. And once the patient is having a shockable rhythm, you usually start directly with defibrillator. Okay. So please remember, it is important. You need to apply defibrillator as soon as possible. And once you are done with 1 to 2 rounds of CPR, also you can directly give a defibrillator. Now you can apply defibrillator, give an electric shock to the patient. Okay. So here are more likely option C would be a correct answer. Okay. Stop CPR while defibrillator is used is the correct option according to me. Moving further, guys. Which of the following inhalational anesthetics require a special vaporizer? Definitely, Dr. Vinayak would have discussed it in great details. Inhalational anesthetics, as we know, the 4 most important are iso, des, sevo, fluorine, and halothane. Apart from that, methoxyfluorine and enflurane are also there, right? Definitely, these are the most common ones used. So all of them will require a vaporizer. And vaporizer ke colors bhi sabko pata honge. Definitely, isoflurane has a purple color of vaporizer. Desflurane has a blue color of vaporizer. Sevo has a yellow color of vaporizer, and halothane has a red color of vaporizer. But among all of these, because usually desflurane has a low boiling temperature, it usually boils at 23 degrees Celsius. That is at room temperature. Okay, desflurane usually boils at 23 degrees Celsius or at room temperature. Therefore, it needs a special vaporizer, and that special vaporizer is known as Tech 6 vaporizer. Okay, that vaporizer is known as Tech 6 vaporizer. So among all the inhalational anesthetic agent, the inhalational anesthetic agent which requires a special Tech 6 vaporizer is known as option B, desflurane. Okay, no issues with this. So it is important. Moving further to our question number 6, a 2-year-old pediatric patient presented in an unconscious state. He was having profound diarrhea and mild pneumonia. In the management of this baby, when we were following A, B, C, D, E, what does D stand for? This you can find definitely in Jaisal's notes, in Nisarg's notes, whereas I have also included in my surgery chanting as well. Okay, in the surgery chanting where we have discussed trauma and everything, where we were following the ATLS protocol and we were following A, B, C, D, E, as I've clearly mentioned over there. All of you are quite aware. हमने class में discussion भी किया था. All of you were quite aware of airway, breathing, and circulation. But next was disability. Okay, as we know, D stands for disability. Though it is not a trauma patient, but when you follow A, B, C, D, E protocol for resuscitation, the most important thing, D stands for disability. याद रखना, ठीक है? D stands for disability. No issues with this. Please remember this. Okay, no issues with this. Definitely diarrhea, dehydration. These are not the options. They have just given that patient is suffering from profound diarrhea to confuse you among diarrhea and dehydration. But A, B, C, D, E, that is your resuscitation protocol. Over there, D stands for disability management. No issues with this, anybody? Please remember that. Next, moving further, guys. This was the question I have discussed in TND session of chanting. Definitely, Dr. Prasanna sir have covered in his videos as well, in his classroom as well. Bluish discoloration of cervix during pregnancy is known as. So this is easy, I hope so. Bluish discoloration of cervix during pregnancy is known as, that we have discussed. It is nothing but option C, Chadwick's sign. It is nothing but Chadwick's sign. These are all the signs which appear during the first trimester of pregnancy, around 6 to 8 weeks, right? We have discussed bluish discoloration of cervix is Chadwick's sign. Purplish discoloration of vagina. Purplish discoloration of vagina is what is known as the Jacqueminot sign. That is what is known as the Jacqueminot sign. Both of these signs will appear around 6 weeks of gestation. Hegar's sign is usually when the abdominal and the pelvic fingers oppose each other. That is not recommended, but it can be done. Okay, important. Goodell sign is nothing but softening of the cervix. Okay, softening of the cervix. No issues with this. That was a straight one-liner. Most of the people I was saying that one-liners aaye the bahut zyada. So that was the thing I was telling you since a lot of time, that don't compromise on one-liners. ये मत समझो कि one-liners नहीं आएंगे exam में. As I've always told you, images also there was substantial amount of images. One-liners भी अच्छे खासे थे. That is the thing. All those who are FMG aspirants for December 2022 session, please remember, guys, one-liners and images have not been totally scraped out of the exam. Okay, they are still coming in the examination, but definitely they are more clinically oriented. इतना याद रखना कि बिल्कुल बंद हो गए ऐसा बिल्कुल नहीं है. ठीक है? So that is you need to remember. Okay, we have discussed about the second trimester signs also, Braxton Hicks contractions, quickening, allotment, all of that we have discussed. Third trimester में lightning sign होती है, that also we have discussed. So each and every sign during pregnancy we have discussed in great details. I don't think so that most of you must have done a mistake over here. Okay, no issues with this. Moving further, which structure is palpated in the given image? So these questions, as I always told you, these are the Sarkari questions, as I always say, repeated multiple number of times, and still they are being repeated in the examination. So this is a question that was a piece of cake for all of you, I feel so. This was a recall question, PYQ from August as well as June examination. So which structure is palpated in the given image? So this is easy. Here you can see the examiner is palpating a pulse. Okay, the examiner is palpating a structure or pulse in between the medial malleolus and the Achilles tendon. Between the medial malleolus and the Achilles tendon, as I told you, in between the Achilles tendon and the medial malleolus, if an examiner is palpating something, definitely is trying to look for option B, posterior tibial artery. So it's palpating the pulse of the posterior tibial artery. Important, right? Dorsalis pedis, as we have already discussed, it is palpated against the navicular bone or between the web space of the first and second metatarsal. Okay, between the web space of the first and second metatarsal, or usually against the navicular bone of the foot. No issues with that. So it was easy, I hope so. Question number 9 says a patient of COPD, chronic obstructive pulmonary disease, presents with respiratory distress, arterial blood gas analysis, ABG. As I've always told you, most important topic, repeated commonly. So ABG was performed and the values are pH 7.25, bicarbonates 28 milliequivalents per liter, and PCO2 65 mm of Hg. What is the acid-base disorder in the patient? As I've already discussed ABG multiple times, Manish sir would have discussed in his notes. I have discussed it in integrated pulmonary medicine sessions, definitely. Apart from that, I have discussed it multiple other times also, because I know that ABG is an important topic. Even before the exam day, I have posted it in the Telegram group also. So at least if you have looked at that specific chart, you would have been able to answer it correctly. So as we all know, the normal pH of the body is 7.35 to 7.45. Anything less than 7.35 is considered acidosis. Anything more than 7.45 is considered alkalosis. And we know there are two deciding factors, whether it is a respiratory component or metabolic component. And those are PCO2 levels and bicarbonate levels. If PCO2 are abnormal, then definitely it is a respiratory cause. And if bicarbonates are abnormal, it is definitely a metabolic cause, right? That we know. Definitely, as I told you, like in NEET PG, if they are giving straight away questions directly for acid-base disorder, definitely here they would not confuse you with partially compensated or totally compensated. So again, it was a straightforward question. So here the pH is less than 7.35, that is around 7.25. That means, as I've always told you, right, first of all, what is the acid-base disorder? It is acidosis, right? It is acidosis. Next, you need to watch for bicarbonate value and PCO2 value. Here you can see PCO2 value is normally 40 mm of Hg, right, as we have discussed. But here the patient is of COPD and now he presents to you with exacerbation. Definitely he's having some respiratory distress. Therefore, there is hypoventilation and there is accumulation of PCO2 and there is accumulation of CO2 inside the body. Therefore, the PCO2 values are very high, that is around 65 mm of Hg. And here the patient is definitely, as we know, CO2 is acidic. So definitely if CO2 values are rising, definitely it is a respiratory acidosis. And bicarbonates value, as we have discussed, normal bicarbonates values are between 22 to 26 milliequivalents per liter. Here it is slightly on the higher side, on the borderline, we can say. It has started compensating. It is not partially compensated. It is not completely compensated yet. It has started compensation just. So anyways, they are not asking you about the compensation. So pH less than 7.35, so acidosis. And as PCO2 is high and bicarbonates are almost normal, so it is a respiratory acidosis. Straightforward question. No issues with that. Moving further, name the type of joint present at the yellow arrow marked region. So here they have marked. So there were two questions and the radio-ulnar joints, I feel so. I'm not sure, please correct me if I'm wrong. There were two questions at the radio-ulnar joint. One was in the middle radio-ulnar joint. Here you can see the middle radio-ulnar joint has been marked and they have asked which type of joint is it. And the second was maybe a wrist X-ray or a wrist image was given, and they have given you the distal radio-ulnar joint and they asked you which movements are being done over here or which type of joint is over there, something that kind of. Please let me know what was that question so I can include it in the subsequent sessions. Okay, so here they have marked the middle radio-ulnar joint, and as we have always discussed, the middle radio-ulnar joint is nothing but an interosseous membrane. Between two bones there is a membrane, and this interosseous membrane is an example of a fibrous joint. This interosseous membrane is a this interosseous membrane is an example of fibrous joint which is not freely movable. Okay, so we have discussed three types of joints. First are the fibrous joints, second are the cartilaginous joints, and third are the synovial joints. As we know, this we have discussed in the last PYQ session. Okay, so fibrous joints, as we know, these are not freely movable. There are three types of fibrous joints. Either they can be the sutures between the cranial bones, they can be gum fosses between the tooth and socket, or the third one is actually a syndesmosis. What do we mean by a syndesmosis? Syndesmosis is nothing but a presence of interosseous membrane between two bones, and that is what is the middle radio-ulnar joint or the superior and inferior tibiofibular joint are a type of. Okay, so this is an example, classical example of option C, syndesmosis. Okay, no issues with that, please remember. Whereas cartilaginous joints, as we know, they can be either primary or secondary cartilaginous joints. Primary cartilaginous joints are nothing but they are called as synchondrosis. Primary cartilaginous joints are called as synchondrosis, whereas secondary cartilaginous joints are called as symphysis. So there has been a classical repeat question of symphysis. They mark an arrow at the pubic symphysis and ask you which type of joint is it. It is a symphysis or a secondary cartilaginous joint. Whereas the primary cartilaginous joint, it is usually the epiphysio-metaphyseal junction. That means the physis or the growth plate, which is usually seen before skeletal maturity. That is what is a classical example of a primary cartilaginous joint or a synchondrosis. Okay, after skeletal maturity, when the physis or the growth plate ossifies, then it would be called as a synostosis. After skeletal maturity, it is what is called as synostosis. And synovial joints are freely movable joints. These are 6 types of joints: ball and socket, pivot, hinge, all of that we have discussed. No issues with that. I hope you have marked it right as well. Moving further, just a minute, I'll connect my lappy to charger. Okay. So let's move further with the next question. Here you can see they are saying that identify the arrow mark structure in the radiograph. So most people have recalled that MRI was given. Okay, MRI lateral view was given of the brain, and this was the arrow mark structure. So the arrow was marked at nothing but option B, pons. Okay, so this is the brainstem image. That is what is given. Here you can see this is the cerebrum. Beneath that there is the corpus callosum. Then there would be a third ventricle that is seen. Then at this level there would be a midbrain. Then here you can see this one. This is your pons. Okay, this one, the yellow arrow mark structure is nothing but your pons. Okay, that you need to remember. This one is your pons. Beneath pons, definitely this one is your medulla oblongata. Okay, and beneath that it continues into the spinal cord. Whereas cerebellum, this fanning structure that you can see behind the brainstem, that is what is your cerebellum. Okay, so previously also I have taken this and recall that they have marked an arrow at the midbrain. This time they marked an arrow at the pons. Okay, so definitely these questions have been repeated commonly, so I don't think so there was any issue you marking it wrong at any point of time. Okay, moving further, guys, question number 12. A patient was having unilateral hypoglossal nerve lesion. Position of the tongue on protrusion is. So as we have discussed in anatomy session also, whereas I have also discussed in the PYQ session also about some important cranial nerves. And as we know, hypoglossal is the 12th cranial nerve. And as we know, the 12th cranial nerve or the hypoglossal nerve will give motor innervation. It is a pure motor nerve and it gives motor innervation to the tongue. Okay, and as I told you, tongue se hamesha ek question aata hai, whether it is on the taste buds or the papillae, or maybe the sensation, general or taste sensations of tongue, or the hypoglossal nerve. Okay, anything, or maybe the muscles of the tongue. Any question can come on tongue definitely, and this was the question this time. A patient was having a unilateral hypoglossal nerve lesion. Now when you protrude the tongue or when you move the tongue, what would be the position of the tongue? So please remember, definitely it would not remain in the midline as there is a palsy in one of the hypoglossal nerve. It will not deviate to the contralateral side. Okay, rather it will deviate to the affected side. So that means if there is a right-sided hypoglossal nerve region, the tongue will deviate to the same side, that is to the right side. Okay, that is what is important to be remembered. Okay, so option C, that is the tongue will usually deviate to the ipsilateral side or the same side of the lesion. So if there is a right-sided hypoglossal nerve palsy, the tongue will also deviate to the right side. That is what is important. So the tongue will deviate to the ipsilateral side and not to the contralateral side. Okay, and when, please remember, when both the nerves would be damaged, then definitely the protrusion of the tongue will not be possible. That is usually seen in bilateral hypoglossal nerve palsy. Okay, so I hope this was easier. Moving further, identify the arrow mark structure in the dissected specimen. So definitely, as I told you, cadaveric images are the current favorites. They give you any type of cadaveric image and they like to ask you questions regarding that. So this is the somewhat confusing here. So I'll just mark it for you. What was the exact question which has been asked? So I'll mark it with the highlighter. So this was the structure which was asked, right? So this was the structure which was marked in the examination. And what is the structure, anybody? So please remember this structure which has been marked over here. So as you can see, this is your vertebra. Okay, this is your thoracic vertebra. Okay, that's fine. Here you can see in front, there is some structure which is dividing. And this structure which is dividing is nothing but the pulmonary artery. Okay, so this is the pulmonary artery which is dividing, or the pulmonary trunk is dividing into the left and right branch. Okay, so left and right branch mein divide ho rahi hai, that is the pulmonary trunk. The in the side of the pulmonary trunk, that is your superior vena cava that you can see over here. Okay, so this one is the superior vena cava that you can see, and in between superior vena cava and pulmonary artery, between superior vena cava and pulmonary artery, this structure that you have, that is the ascending aorta. This one is the ascending aorta. No issues with this. So please remember, this one is the ascending aorta in between the superior vena cava and the pulmonary artery. अगर उससे पीछे आते हैं हम, that you can see over here, this is the vertebra at the posterior most aspect, and this is your esophagus. Just beneath the esophagus, or just on left side of the esophagus, the structure that you can see is nothing but your descending aorta. Okay, it is the descending thoracic aorta that you can see over here, just on the left side of your esophagus that you can see, it is your descending aorta. No issues with that. So please remember, this was the structure. The yellow mark structure has been marked in the examination, and that is nothing but your descending aorta. Okay, esophagus ke just on the left side, it is your descending aorta. Okay. Moving further, now question number 14. A patient presents to the emergency with pain and swelling in the right shoulder. A fracture of clavicle is suspected. The most common site of fracture is. So as we know, clavicle is one of the favorite topics the examiners have. And clavicle is the most commonly fractured bone inside the body. As we know, there can be multiple causes of clavicular fracture. One of the common ones that we have discussed is shoulder dystocia, right? But usually clavicle is the most common bone fracture in any age group that you need to remember, right? And they have asked just what is the most common site of clavicular fracture. So as we know, the most common site of clavicular fracture is option D, junction of the medial 2/3 and the lateral 1/3. So something this type the clavicle looks. So over here, okay, so clavicle is divided into the medial 2/3 and the lateral 1/3, and the junction is the most common site of fracture usually. Or sometimes the clavicle can be divided into three zones as well. Okay, one is the medial zone, the other one is the middle zone, and the other one is the lateral zone. Okay, so here they can also write it as the junction of the middle 1/3 and the lateral 1/3. Okay, it can also be written as the junction of middle 1/3 and the lateral 1/3. Or most of the people directly write it as junction of the medial 2/3 and the lateral 1/3. That is what is the most common site for your clavicular fracture. No issues with that, and figure of 8 bandage is applied, as we all know, in clavicular fractures. No issues with this. So I hope this was pretty easy for all of you. The muscle in the mark structure is involved. Which of among the following action will be compromised at the shoulder joint? So they are saying that the muscle in the mark structure. So what is the mark structure? The structure which is marked in red, it is nothing but the supraspinatus fossa. It is nothing but the supraspinatus fossa. You can see there is the scapular spine, and above the scapular spine there is the supraspinatus fossa. Beneath the scapular spine there is the infraspinatus fossa. And we know the muscles which are originating from the supraspinatus and infraspinatus. So these are usually the supraspinatus muscle and the infraspinatus muscles respectively, right? And as we know, these are the part of the rotator cuff muscles usually. So whenever the patient will have a frozen shoulder, whenever all the actions of the shoulder would be restricted, definitely these muscles would also be affected, right? So here the patient is having some injury due to which the muscle in this fossa that is paralyzed. So the muscle in the fossa is nothing but the supraspinatus muscle. And if supraspinatus muscle is affected or usually it is paralyzed, then which action would be affected? So as we know, usually from 0 to 15 degree abduction, 0 to 15 degree abduction is the responsibility of supraspinatus muscle. It is called as the initiator of shoulder abduction, right? So shoulder abduction is initiated by supraspinatus muscle, 0 to 15 degree supraspinatus, 15 to 90 degree deltoid, and overhead abduction or above 90 degree abduction at trapezius, usually trapezius or serratus anterior muscle. That we have already discussed. So this time they did not ask you about deltoid or trapezius or serratus anterior. Rather, this time they asked you about the supraspinatus one, that is the initiation of abduction. So definitely, if supraspinatus muscle is being paralyzed, definitely option A, abduction function would be compromised in the patient. Okay, abduction 0 to 15 degree abduction would not be possible. Okay, we have discussed this in ortho anatomy. हर एक जगह पे discuss कर लिया था. I've discussed about frozen shoulder where all the movements of the shoulder are affected. I've even discussed about the painful arc syndrome or the impingement syndrome where usually 60 to 120 degree of abduction is affected. Right? So that I've already discussed. No issues with that now. Moving further, identify the arrow mark tendon. So here definitely, as we have discussed in anatomy session also that we did usually in the last few days. So this is nothing but the anatomical snuff box. As I've told you, the depression that you can see usually beneath the thumb, that is nothing but your anatomical snuff box. So the structure that is seen over here on topography, this is nothing but the anatomical snuff box. And as we know about the anatomical snuff box, usually the boundaries you need to remember. And here they have marked the posteromedial boundary. They have marked the posteromedial boundary. This one, this tendon is the posteromedial boundary of the anatomical snuff box. And as we know, the posteromedial boundary of anatomical snuff box is formed by option C, extensor pollicis longus. It is formed by extensor pollicis longus. Whereas the anteromedial boundary, this one, the anteromedial boundary is formed by two tendons. Okay, anteromedial boundary is formed by two tendons, and those are abductor pollicis longus and extensor pollicis brevis. Okay, the two tendons which form the medial boundary or the anteromedial boundary are abductor pollicis longus and the extensor pollicis brevis. No issues with this. Important. And as we know, the content is usually the radial artery. Okay, एक बार content पूछ चुके हैं, एक बार boundary पूछ चुके हैं. So इस बार again they have asked you about the boundary. So याद रखना, posteromedial boundary is formed by extensor pollicis longus, whereas the anteromedial boundary is formed by two tendons, abductor pollicis longus, whereas extensor pollicis brevis tendon. No issues with that. Whereas the content is radial artery. Roof is formed by the skin and the subcutaneous tissue, whereas floor is formed by scaphoid and trapezium bones. Okay, all of this we have discussed already. Moving further, guys, the marked plane in yellow corresponds to, okay, the marked plane in yellow corresponds to which vertebral level? That is important. So here you can see there are various planes. Okay, these two lines that you can see, these are nothing but the mid-clavicular lines which usually pass from the nipple. Important. Whereas the horizontal lines that you need to see, the horizontal planes that will divide the abdomen into 9 quadrants. Okay, these horizontal planes, these are 3 important horizontal planes that we have discussed in anatomy also. The first one that you can see, definitely Dr. Anika ma'am have also discussed in our sessions. The first plane that you can see over here, it usually passes from the pylorus of the stomach. Okay, it passes from the pylorus of the stomach from the epigastrium, and therefore it is called as the transpyloric plane. Okay, the dotted line. The next one that I have marked in yellow, here you can see it is beneath the costal margins. Beneath the costal margins. So, जो coastal margins के नीचे जो होता है, that is what is a subcostal plane. That is what is a subcostal plane, right? Whereas important thing, the plane that you can see, which is beneath the umbilicus, it is nothing but the transtubercular plane. It is the transtubercular plane which will join the two iliac, which will join the two iliac tubercles, or the which will join the two iliac tubercles. And iliac tubercles क्या होते हैं? Those are the highest point on the iliac crest. Okay, so highest point on iliac crest are called as iliac tubercles, and the line joining these two iliac tubercles is nothing but the transtubercular line or the transtubercular plane. As we know, if I talk about the levels, the vertebral levels which they correspond to, important, please remember, usually the transpyloric plane. Some of them are saying definitely borders bhi diye gaye the, upper border, lower border in 2 of the options. I'm not sure. But anyways, I'll tell you about the borders as well. So please remember, transpyloric plane is usually at the lower border of the L1 vertebra. Okay, so please remember the transpyloric plane usually passes at the lower border of the L1 vertebra. whereas the subcostal plane usually passes at the upper border of the L3 vertebra. It usually passes at the upper border of the L3 vertebra, whereas the transtubercular plane, it usually passes at the upper border of the L5 vertebra. It passes at the upper border of the L5 vertebra. कैसे याद रखना है? Umbilicus is usually at the level of L4. It is usually between L4 and L5. याद रखना. Please remember, umbilicus is between L4 and L5. So that is how you can easily remember. Subcostal is above umbilicus, therefore it is L1 vertebra, lower border. It is L3 vertebra, the upper border, whereas the transtubercular plane is usually at the L5 vertebral level. No issues with that. Please remember this. Previously, they have definitely asked you about this. Previously, they have been asking you about celiac trunk, superior mesenteric and inferior mesenteric artery levels as well. That we have already discussed. I've also discussed about the planes and anatomy session of mine. Okay, so I don't think so there would have been much difficulty. Definitely, it was confusing a bit. Most of you would not be sure if it is a transpyloric or a subcostal plane. Okay, but anyways, if you were able to make it out, then great. No issues with this. Moving further. The person achieves sexual gratification by getting beaten or inflicting pain from the partner. It is known as. So I hope all of you were able to answer it. If the patient is achieving sexual gratification or getting sexual arousal by getting beaten by his partner or by getting inflicted pain from the partner, this is nothing but option A, masochism. This is what is known as a masochism, which is a type of sexual paraphilia. Whereas if the patient is achieving sexual gratification or getting sexual arousal by giving pain to the partner or inflicting pain on the partner, then that is what is sadism. Okay, no issues with that. Previously, they have asked you about satyriasis and nymphomania, excessive sexual desire in males and females respectively. Lesbianism can be easily ruled out. It is not a sexual paraphilia, as we know. Okay, lesbianism, it is not a sexual paraphilia. Okay, sexual feelings towards the same sex, that is what is lesbianism. No issues with this, anybody? Please remember this. Moving further, a person while taking ward rounds is asked, what is your name? So this question has been asked to the patient, what is your name? The patient repeats the same sentence, what is your name? Okay, so if the patient keeps on repeating the same sentence or whatever the examiner has said, then this phenomena is known as nothing but option B, echolalia. Repetition of the same words or same sentence is what is echolalia. Whereas repetition of same movements is what is known as echopraxia. Repetition of same movements is known as echopraxia. And as we know, echolalia and echopraxia are a feature of catatonic schizophrenia, where the motor symptoms are predominant usually, right? So echolalia and echopraxia are features of catatonic schizophrenia. So echolalia is repetition of the same words of the same sentence. Perseveration kya hoga? Most of you might be confused with this. So as we have discussed already, what is perseveration? Guys, please remember, when you ask somebody, what is your name? And he says, Omkar. When you ask the next question, where do you live? He says, Omkar. When you asked, where do you study? He says, Omkar. So he keeps on repeating the same answer. Okay, that is what is perseveration. He keeps on repeating the same answer beyond a point of relevance. That is what is perseveration. Okay, repetition of same sentence or same words is what is echolalia. Okay, circumstantiality, when you ask a question to the patient, but he, rather than answering that particular question, he keeps on revolving here and there. What is your name? So he'll say, India is a great country. I like to live in India. India has different languages, diversity, all of that. And finally, he'll answer your question. My name is Omkar. Then this phenomenon is what is known as circumstantiality. No issues with that. Please remember this. Question number 20 now. A female patient wants to stop tobacco intake. Which among the following drugs shall be used? So I'm not sure about the other options which were there. Definitely one of the first line agents that we use, that is nicotine replacement therapy. But most of the people who have given me the recall have said that nicotine replacement therapy was not in the option, definitely, right? So NRT can be was not an option. So definitely we need to look for another options. And here the best option was option E, varenicline. Varenicline, as we know, it is alpha 4 beta 2 partial agonist. It is alpha 4 beta 2 partial agonist. Okay, and therefore it helps usually in cases of tobacco de-addiction. It helps in cases of tobacco de-addiction or to help against the tobacco withdrawal. Okay, as we know, please remember, guys. Bupropion is one of the agents that can be used. It was not buspirone, it is bupropion. Okay, bupropion is also one of the agents used for anti-smoking medication. Used as an anti-smoking medication, bupropion. It is actually an antidepressant drug. Okay, so antidepressant drug like bupropion, it is used as an anti-smoking drug or smoking cessation के लिए use किया जाता है. Buspirone, please remember, it is an anxiolytic drug. Buspirone is an anxiolytic drug to overcome anxiety in a patient. Okay, so this is an anxiolytic drug. Other options, please let me know if you are able to recall the other options too. Okay, please remember that. Moving further, guys, now, as we have discussed about alcohol withdrawal, alcohol withdrawal is also one of the common questions, and there the drug of choice would be benzodiazepines. The specific drug which is preferred is chlordiazepoxide, as I've already told you. Next, question number 21 says, a pregnant female presents to you with bipolar disorder. Which among the following treatment option you will likely avoid in the patient? So some people are saying, they have asked which among the following treatment option would be employed or used. Some people are saying, most of the people have given me a recall that which among the following treatment option you will likely avoid in the patient. Okay? So that was the question. Here they are saying a pregnant female with bipolar disorder. If I talk about bipolar disorder, as we know, there would be episodes of mania or hypomania followed by depression in the patient, right? That is what is a bipolar disorder, right? And in bipolar disorder, as we know, if the patient presents to you in acute mania, then the drug of choice would be atypical antipsychotic. Then the drug of choice, as we know, it is not lithium, it is atypical antipsychotics. Drugs like olanzapine can be given. Okay, whereas the better answer would be olanzapine plus lithium. Lithium is a mood stabilizer. Okay, it is used for prophylaxis. So if they only mention drug of choice for bipolar disorder or drug of choice for prophylaxis of bipolar disorder or prophylaxis of mania, then your single best answer would be lithium. Otherwise, if they mention about acute mania, if the patient is having rage symptoms right now, then definitely the first line should be olanzapine. Okay? So here, they were more likely asking you about prophylaxis of bipolar disorder usually, and what are all the treatment options you will use, but you will likely avoid which one of the following. So option A says carbamazepine. Carbamazepine, most of you are confused. It is a category D drug, guys. Please remember, carbamazepine is an anti-epileptic drug, but that falls in the category D. What do we mean by category D? That means these drugs can be used if the benefits outweigh the risk. Okay, if these drugs can be used if the benefits are more than the risks. So ऐसा नहीं है कि carbamazepine is absolutely contraindicated during pregnancy. Please remember this. Okay? So carbamazepine can be given during pregnancy as well if the benefits are more than the risk in the patient. Okay? There would be a high probability of neural tube defect. So therefore, we will likely avoid it during the first trimester of pregnancy. But beyond that, we can give carbamazepine also if the patient's life is at danger. Okay? Then if I talk about olanzapine, guys, definitely olanzapine would be given to the patient to avoid mania, because agar patient mania mein jati hai, there is a irresistible desire, the patient is hyperactive, there's a high chance of miscarriage. Okay, the patient will abort herself. So therefore, olanzapine would also be given. ECT is also one of the safer options that is to be given in the patient. Okay, yaad rakhna, yes, pregnancy mein dete nahi hai usually, but ECT can be given in the patient of bipolar disorder of severe depression if the patient is having suicidal tendencies. Aisa nahi hai, bilkul hi contraindicated hai. Okay, so if the patient is having suicidal tendencies, then definitely ECT can also be used. Aisa nahi hai, ECT is unsafe in any trimester of pregnancy. It can be given if there are suicidal tendencies, because then the mother's life is at danger, and therefore you need to prevent that. Okay, so suicidal tendencies, so in BPD or in severe depression, definitely ECT can also be employed. Lithium is likely to be avoided in the patient, guys. Why? Because as we know, lithium is associated with a teratogenic side effect, and that is what is called as Epstein's anomaly. Again, a sarkari question, but this time they have asked you in the other way around. Okay, so here you will try to avoid lithium because it is associated with Epstein's anomaly in the fetus, and Epstein's anomaly will lead to a box-shaped heart, and that is not usually compatible with life. The patient, the child will die early in the course only. Okay, so better to avoid such a drug which will lead to Epstein's anomaly, and the child could not live longer. Okay, yeah, no issues with this, anybody? Please remember. Moving to question number 22, which anti-thyroid drug is safer during the first trimester of pregnancy? So I hope this was easier for all of you. Anti-thyroid drug that is safer throughout pregnancy or during the first trimester of pregnancy. The safest anti-thyroid drug, we have discussed it in OBG, pharma, almost everywhere in every chanting session. Dinesh sir, definitely Prasan sir would have given you it multiple times, right? So this is a recall question again. So the safest anti-thyroid drug or hyperthyroid drug during the first trimester of pregnancy is nothing other than option D, propylthiouracil. It is PTU, propylthiouracil. Whereas in first trimester, we try to avoid the anti-thyroid drugs like carbimazole or methimazole, because as we know, we have discussed it in classroom that these are usually associated with important teratogenic side effects like cutis aplasia or choanal atresia, and therefore we try to avoid them in the first trimester. But as these are more efficacious as compared to PTU, therefore we try to replace these PTU after the first trimester. The first trimester, you will give PTU to the patient. But usually in second or third trimester, again the drugs of choice would be carbimazole or methimazole. कोई दिक्कत नहीं है. And radioactive iodine, as I have discussed in ops, classically मैंने जो YouTube पे session लिया था, I have classically mentioned that radioactive iodine is absolutely contraindicated during any trimester of pregnancy. Radiotherapy कभी नहीं देते हैं. Okay, no issues with this, anybody? Moving further, guys. Which among the following is the most common cause of postmenopausal bleeding? So if they ask you which among the following is the most common cause of postmenopausal bleeding, some of the people are saying CS cervix was there in the option, but I also doubt, and most of the people have also told me that CS cervix was not there in the option. Okay, according to Indian scenario, definitely the most common cause of postmenopausal bleeding is CS cervix. Okay, whereas I've always told you, in the Western world, the most common cause of postmenopausal bleeding is option B, endometrial atrophy. Yaad rakhna, it is not endometrial hyperplasia. Endometrial atrophy is the most common cause of postmenopausal bleeding. This is nothing but senile endometrium, what it is called as. Okay? So senile endometrium or old age endometrium will lead to endometrial atrophy, leading to postmenopausal bleeding in the Western world. Whereas second most common is endometrial hyperplasia, followed by it is endometrial carcinoma. So yaad rakhna, carcinoma is not the most common cause of postmenopausal bleeding. Okay, whereas in Indian scenario, if they ask you, definitely CA cervix is the most common cause for postmenopausal bleed or for postcoital bleed. Okay, India mein dono ki most common cause would remain CA cervix. No issues with this, anybody? So here the answer would be option B, endometrial atrophy. Ye bhi I have discussed it in classroom. Question number 25. Secondary postpartum hemorrhage is defined as. So most of the people were usually during QRS, when I start my session with OBG and start with postpartum hemorrhage, and I try to make people learn the definitions, they are like definitions क्यों रटवा रहे हो? So this is the reason why I actually make you learn definitions, okay? Because most of the times they directly ask you definitions, and if you make mistakes in the definition, definitely that is a silly mistake. Okay, that should be avoided. So please remember, secondary postpartum hemorrhage, as we know, it is nothing but, as we know, bleeding from 28 weeks. ये तो मैंने definition in the previous day I have posted it in Telegram group also, right? APH की definition, PPH की definition. So from 28 weeks of intrauterine life till birth, whatever bleeding occurs, this is what is called as the antepartum hemorrhage. Antepartum hemorrhage के तीन types के bleed होंगे. There are two causes of painless bleeding, that is placenta previa and vasa previa, and one cause of painful bleeding, that is abruptio placentae. These are all types of antepartum hemorrhage. Whereas, please remember, if the bleeding usually occurs after delivery, then it is what is called as postpartum hemorrhage. As we have discussed, PPH or postpartum hemorrhage can be either primary or secondary PPH. So primary PPH is usually within 24 hours of delivery, right? It is within 24 hours of delivery. Whereas secondary PPH, as we know, it is after 24 hours of delivery till 12 weeks of delivery. Now, please let me know, most of the people are saying the exact definition was given till 12 weeks of delivery. Some people are saying that 12 weeks was not there in any option, 6 weeks was given. So whatever it is, if it is from after 24 hours of delivery till 6 to 12 weeks of delivery, it is considered as secondary postpartum hemorrhage. For postpartum hemorrhage, overall, the most common cause, as we know, it is atonic uterus. Whereas for secondary postpartum hemorrhage, as we have discussed it, as I've given you the succinsurate lobe, that is the first page of our QRS session. The most common cause for secondary postpartum hemorrhage is nothing but retained tissues or succinsurate lobe of placenta. Okay? याद रखना, कोई दिक्कत नहीं है. Within 24 hours is primary PPH. After 24 till 12 weeks is secondary PPH. Moving further, guys, a female has to undergo medical termination of pregnancy (MTP). At what period of gestation will she require approval of 2 doctors? Now, बहुत सारे लोग बोल रहे कि 2 doctors थे, कुछ लोग बोल रहे कि 1 doctor था. I'll give you answers for the both of them. Okay, ठीक है? So please remember, most of the people who are in contact with me, they have given me a recall of 2 doctors. इसलिए मैं 2 doctors का बता रहा हूँ. A female has to undergo MTP. At what period of gestation will she require approval of 2 doctors? This we have discussed MTP in great details. From the method of MTP, जो जिस पे 2 question आए हैं. One is on doctors, second was on the drugs that we have discussed in classroom, right? So definitely, as we know, the patient usually now in India, according to the recent amendment that we have discussed, the patient can undergo MTP up to 24 weeks of gestation or 24 weeks of pregnancy. From 12 to 20, from 0 to 20 weeks or 12 to 20 weeks, the doctor will, okay. So the patient will require 1 doctor opinion. From 12 to 20, the patient will require 1 doctor opinion. Agar 1 doctor था option में, then the answer would have been 12 to 20 weeks. from 20 to 24 weeks, the patient will require two doctor opinion. From 20 to 24 weeks, as it is a high risk termination of pregnancy, the patient will require two doctor opinion from 20 to 24 weeks. And as we know, from 20 to 24 weeks, usually termination of pregnancy is only indicated if the patient is either a rape victim or the patient is a victim of incest, that is sexual relation and blood relation, or if the patient has a failure of contraception, if the patient has a failure of contraception, or on humanitarian grounds, like just like the rape victim or an incest victim. Okay, so these are usually the indications, or if the patient fetus is having some congenital anomalies like Down syndrome. Down syndrome is not an indication of MTP, but other congenital anomalies are definitely an indication of MTP, okay, which are incompatible with life. Apart from this, definitely if the mother's life is at danger. So these are usually the indications. Mother's life is in danger or mother's life is at risk, then definitely these are indications for MTP during 20 to 24 weeks. And here you will require two doctor opinion. No issues with this, anybody? Moving further, guys, now. So moving further, question number 26. A 34-year-old woman presents after 6 weeks of delivery. She wants contraception for the next 3 years. What will be the best contraceptive in this case? So I hope all of you are quite aware. Usually in the lactation, definitely we use POPs, progesterone only pills, lactation pills or mini pills. But यहाँ पे उन्होंने catch डाला है, ठीक है? The patient presents to you after 6 weeks of delivery. That means the patient presents to you usually in lactation period, ठीक है? ये यहाँ तक होता तो definitely POPs would have been my best answer that I would have marked. But she wants contraception for the next 3 years, they are saying, okay? So why not POPs? याद रखना, POPs usually are used during lactation only. That means till 1 year after delivery. Okay, so 12 months after delivery you can use POPs, but POPs will not lead to periods in the patient. Okay, POPs, as they are having high dose of progesterone or high dose of levonorgestrel, they will lead to interruption of periods in the female. Okay, the patient will not have periods at all, and therefore due to this, as the patient will not have periods, to avoid that, usually we do not prefer POP on a long term. If they are saying the patient needs contraception for the next 3 years, so for long-term contraception, the better answer would have been option B, copper T IUCD. Okay, so copper T IUCD, which is associated with less complications, the periods would be regular. The patient will not have any issues in the periods as such. Okay, and it will give contraception as well. So the better option for long-term contraception, even after delivery, is copper T IUCD. No issues with that. So barrier methods are definitely not indicated because of high failure rates. OCPs are not indicated usually after delivery immediately. Okay? A 20-year-old pregnant female at 7 weeks of gestation presents to you for medical termination of pregnancy. Which among the following drug is used for MTP? This we have discussed it in great details. इसमें दिक्कत किसी को नहीं थी. Most of the people are saying कि misoprostol में कोई dose नहीं दिया हुआ था. Some people are saying कि misoprostol का भी dose था. Okay? Anyways, we have discussed it in with doses. ठीक है ना, doses के साथ हमने discuss किया था in our sessions. So I don't think so if doses would have been there also, you would have any problem to mark it. So usually till 7 weeks of delivery, medical termination of pregnancy is usually done by medical management. That means with the help of drugs. You can do it till 9 weeks also. You can do it till 9 weeks also, but better results are till 7 weeks only. Okay. As we have discussed, between 8 to 10 weeks, we prefer suction and evacuation with the carbon cannula. At around 10 to 12 weeks, we prefer dilatation and curettage, right? Dilatation and curettage. And beyond 12 weeks, we definitely prefer a single agent, that is prostaglandin analogs like misoprostol would be preferred after first trimester. No issues with this, anybody? So yaad rakhna. So here, usually the patient is less than 9 weeks or less than 7, at 7 weeks usually. So definitely we need to prefer drugs. And which of the following drugs are preferred for MTP? So you need to remember, first we give an anti-progesterone, that is RU486. The drug is also known as mifepristone, and that is given 200 mg, right? That is given 200 mg. Followed by that, we give a prostaglandin analog. So mifepristone is given initially to kill the fetus, 200 mg, followed by misoprostol, which is given to expel out the fetus. Okay, misoprostol, as we know, it is a prostaglandin analog. It will induce contractions or it will induce labor, and as it will induce contractions, the fetus will be expelled out, the dead fetus. Okay. So the sequence is mifepristone followed by misoprostol, and the doses are mifepristone 200 milligrams, whereas misoprostol around 400 micrograms. For first trimester, it is misoprostol 400 micrograms, 2 tablets. Each tablet of misoprostol is 200 mcg. Okay, so 2 tablets are to be given either per vaginally or per orally can be given. Okay, misoprostol. Whereas after 12 weeks, definitely the dose of misoprostol will be around 600 to 800 mcg because the size of fetus has been increased now. Okay? So the best answer till 7 weeks of delivery is 200 mg of mifepristone first, followed by 400 mcg of misoprostol then. Okay, no issues with that. Moving further, question number 28. Identify the image. I don't think so there should have been problem because similar image was discussed with you in OBG sessions. ठीक है, हमने तो हर एक टाइप का fistula discuss किया था, so there should not have been any problem. Here they have magnified the image also. There is a fistula. अगर magnified नहीं भी था, then also it is easy. Here you can see there is a fistula or abnormal connection between two organs. As we know, abnormal connection with skin is known as sinus. Abnormal connection with organ is known as diverticulum. Whereas abnormal opening or abnormal connection in between two organs is what is known as a fistula, right? And here you can see a fistula which is seen between the vagina and the bladder, urinary bladder. So here we have the urinary bladder. This is the uterus, this is the cervix, and this is the vagina. And behind we have the rectum and the anal canal. No issues with that, anybody? So here you can see a abnormal opening or a fistula between the vagina and the urinary bladder, and this is nothing but option A, vesico-vaginal fistula. This is a vesico-vaginal fistula. As we know, it is the most common type of fistula. The most common cause is usually abnormal conduct of labor or usually obstructed labor, or there can be some injuries to the birth canal during delivery. Maybe some instrumental deliveries can be a cause. Okay, no issues with that. And there are three types of vesico-vaginal fistula: upper, mid, and lower. And out of these three, the mid vesico-vaginal fistula is the most common type of fistula. No issues with that. So, no issues. Ureterovaginal fistula is an abnormal opening between the ureter and the vagina. Here, if we perform a 3 cotton swab test, okay, usually the upper cotton swab is wet. Okay, that is what is the ureterovaginal fistula. Rectovaginal fistula is between the rectum and the vagina, right? Whereas ureterocervical fistula or ureterovaginal fistula is between the urethra and the vagina. No issues with that, anybody? So this was an easy question. I don't think so there would have been any issues with this. One more question was there of a cystocele. Please let me know what was that question exactly. The patient was having a cystocele and what was the treatment option. But I need to know the age. According to age, as we have already discussed in our class, the treatment option would have been decided. If it is an elderly patient, definitely you will go for Ward and Mayo's operation, that is total abdominal hysterectomy or pelvic hysterectomy, vaginal hysterectomy along with the pelvic floor repair. If it is a younger female, you will definitely 30 to 40-year-old, you will go for a Manchester repair or a Fothergill's repair. Okay, and if it is a nulliparous female, you will go definitely for a sling surgery, that is Shirodkar sling surgery. So let me know that what was that question exactly. A patient who was diagnosed with breast cancer and was started on tamoxifen now presents with complaints of bleeding per vagina. What is the cause? Okay, so I hope so. This is the important and a very easy question for all of you. Surgery, OBG, pharma, तीनों में discuss कर चुके हैं. Definitely, as I've discussed, if a patient is diagnosed with breast cancer, and definitely if she's treated with some hormonal drugs. Hormonal drugs are drugs like tamoxifen or raloxifene. These are nothing but SERMs. SERMs are what? Selective estrogen receptor modulator. These drugs are selective estrogen receptor modulator, right? So definitely these will increase the estrogen exposure to the body, and high estrogen exposure to the body will definitely land up the patient in cases of endometrial cancer, right? And as we have discussed, there are 2 types of SERMs. We have either tamoxifen or the safer drug, that is raloxifene. Okay, both of these drugs, as we know, they will decrease the incidence. They will decrease the incidence of breast cancer or ovarian cancer. They will decrease the incidence of breast cancer or ovarian cancer. But on the other hand, tamoxifen will increase the risk of endometrial cancer. ये same question discuss कर चुके थे हम, right? So the patient will have a high risk of endometrial cancer, and that is the reason behind her bleeding per vagina. Okay, no issues with that. याद रखना. So please remember, uterine leiomyoma or fibroids is definitely a benign tumor, and it is not associated with usually tamoxifen therapy. Okay, it is most likely to be an endometrial cancer which is seen. Okay, no issues with this. Cervical cancer की भी risk बहुत ज़्यादा कम होती है. It is more likely the most common cancer on a patient in a patient on tamoxifen therapy is endometrial cancer. Okay, so please remember this. Raloxifene is a safer drug, a bit safer drug, because as we know, in raloxifene, usually the patient will not have a high risk of endometrial cancer. It will decrease the risk of breast and ovarian cancer, but not increase the risk of endometrial cancer as such. Okay, basically raloxifene nowadays is preferred one. the following instrument is used for? Definitely some of these questions are googly, as I told you. Maybe if you have attended my earlier sessions, there I have discussed this one. But if you have not, then you would have missed out on this. So this one is the cannula. This is what is known as the Leach-Wilkinson cannula. So अगर नाम पूछा गया था, तो the answer is Leach-Wilkinson's cannula. This one is the Leach-Wilkinson's cannula. Usually identifying instruments would be easier once you are done with your internship, and that is what they are actually checking. Okay, उनको पता है कि foreign medical universities में usually there is not much of exposure, and therefore they try to test your clinical knowledge as much. So here they have given you a cannula, that is Leach-Wilkinson cannula, and this Leach-Wilkinson cannula is used for a procedure known as option B, hysterosalpingography. When we inject a dye into the vagina, into the cervix, and then into the uterus, and then we observe the dye going into the fallopian tubes for the tubal patency or for the uterine anomalies. Okay, the procedure that we do is known as hysterosalpingography, HSG, जिसको short में बोलते हो. And for that, injecting a dye, or that if we inject a dye, it is usually done with this Leach-Wilkinson cannula. Leach-Wilkinson cannula. No issues with this, anybody? याद रखना. Moving further, we have discussed about all other instruments. Okay, ठीक है, but इस बार उन्होंने अलग instrument दी थी. We have discussed about Hegar's dilator. We have discussed about uterine curette, uterine sound, Carman's cannula, which has been commonly asked. Okay, this time we asked you about the Leach-Wilkinson cannula. No issues with this. Moving further, identify the below given HSG image. So hysterosalpingography is this one, which appears something like this. When we inject a dye and take serial radiographs to check for the movement of dye into the uterus or into the fallopian tubes. Okay, to check for their patency, कि कोई anomaly तो नहीं है, कि या tubal patent है या नहीं है, या blocked है tube. For that we do usually a hysterosalpingography. So here you can see that which of the following is seen over here. So here it is definitely not a unicornate uterus. Unicornate uterus would be something like this that I've already discussed with all of you. Septate uterus may definitely this kind of a picture is usually seen. Okay, in septate uterus, usually this kind of a picture is seen, right? And with, as we have discussed, there's a dip. Okay, at the fundus there would be a dip, and the angle between the two horns, usually in between the two horns, would be more would be less than 70 degree. It would be less than 70 degree, and the distance would be less than 4 centimeter. And if it is more than 4 centimeter or more than 105 degree, it to be a bicornate uterus. But यहाँ पे ऐसा कोई dip नहीं दिख रहा into the fundus. Rather, there's a cavity which is seen. Okay, why this cavity is seen? Because here there are some abnormal adhesions in the uterus. And as I've discussed, I've given a MRI image in my session, right? So here they have asked you about the HSG image. So it is usually due to some abnormal adhesions or connections in between the uterus, which is more likely due to overzealous curettage. बहुत ज़्यादा जोर से curettage कर दिया किसी ने, okay? या फिर because due to a previous history of pelvic inflammatory disease, the patient was having adhesions inside the uterus, and therefore the dye cannot travel properly to each part of the uterus. And where the dye could not travel, that is the black part that you can see over here. Okay, this black part here, the dye could not travel because there are adhesions formed. So this is nothing but intrauterine adhesions. That is what is Asherman syndrome. Treatment of choice, as we have discussed, it is hysteroscopic adhesiolysis. Okay. Moving further, what will be the content in the given contraceptive? PSM में discuss कर चुका हूँ मैं OBG में discuss कर चुका हूँ. This was the image that I have already told you. मैंने बताया भी था. It is famous by the brand name. So whenever I used to talk about vaginal sponge, which is one of the barrier methods of contraception. So along with vaginal sponge, I used to tell this. Okay, every time I've discussed this, okay, today is the brand name with which vaginal sponge is famous. Okay, so vaginal sponge is nothing but available with the brand name today. And whatever barrier methods that we use, that is whether a vaginal sponge, vaginal diaphragm, or any female or male condoms, whatever barrier method that we use, guys, here you will require a spermicidal jelly because the failure rates are much higher. Therefore, you will require a spermicidal jelly for contraception. And this spermicidal jelly contains a chemical known as option A, non-oxynol 9. ये भी मैंने discuss कर रखा है. This was a recall question again. It was easy. I hope so. No one of you have made mistakes over here. I've even discussed about the male contraceptive pill, that is what is known as Rossipol. Okay, made from the cotton Chinese seed oil. ठीक है? याद रखना. DMPA usually I've discussed. It is a Depo contraceptive or a long-term contraceptive which is given every 3 months. That is Depo-medroxyprogesterone acetate, and it is available. It is the only injectable contraceptive available in Indian family planning program, and this DMPA is usually available by the brand name Antra. Okay? We have also discussed about Centroman, that is Saheli, now now famous by the brand name Chaya. Okay, so no issues with that, anybody? So please remember. Okay, so just give me a minute. Yeah. Levonorgestrel, usually it is present in progesterone only pills, whereas ethinyl estradiol plus levonorgestrel, these are present in combined oral contraceptive pills, that is drugs like Mala and or Mala D. No issues with that. Moving further, question number 33, identify the below given condition. This was the classical question, the exact image that I discussed in Ofta chanting, in QRS session, in TND, everywhere we have discussed about this, right? There was no reason to mark it wrong, I hope so. So this is what you can see, it is a corneal ulcer and it is having finger-like projections, and therefore it is what is called as the dendritic ulcer. And as we know, dendritic ulcer is commonly repeated sarkari question tha pehle. Dendritic ulcer ki most common cause is HSV1, that is herpes simplex virus 1. So this is nothing but a viral corneal ulcer, or option B, viral keratitis, right? Fungal keratitis, as we know, as we have discussed it in great details, it is a ring-shaped ulcer with presence of hypopyon usually, right? And there would be satellite lesions due to the fungal hyphae surrounding the main ulcer, right? And this ring-shaped ulcer will have some feathery margins. So that is what is the fungal ulcer or fungal keratitis. So that is easily ruled out. Bacterial keratitis, as we know, we have discussed, bacterial keratitis will not have some dendrites, okay? Bacterial keratitis will be a round ulcer, maybe a numelar or a coin-shaped ulcer that can be seen. Acanthamoeba ulcer can be, okay, please remember, acanthamoeba ulcers can be dendritic, but it is very rare, very rare. Okay, yaad rakhna. Acanthamoeba ulcer is commonly associated with contact lens users. The most common corneal ulcer in contact lens users is Pseudomonas, but most specific corneal ulcer in contact lens users is acanthamoeba. Most painful ulcer is acanthamoeba. Acanthamoeba can have various shapes and sizes. It can be a ring-shaped ulcer, it can be a dendritic ulcer, anything it can be, but it is very rare, and therefore my first choice is definitely viral keratitis, and this is a classical case and classical picture of herpes simplex virus keratitis or a dendritic ulcer. No issues with that. Drug of choice, as we know, these are 3% acyclovir drops. Even I have discussed with you about the pseudodendritic ulcer. Okay? So pseudodendritic ulcer के बारे में मैंने discuss किया था. In pseudodendritic ulcer, as I've told you, it is caused by herpes zoster virus, and there we need to give oral acyclovir 800 mg. Okay, so that everything we have discussed. No issues with that. Please remember. Moving further, guys. Now talking about the next one. This people are saying this was a one-liner. Some people are giving me a recall key. It was a clinical question. Please clarify whatever it was. But if this was mentioned, nothing to look for. Okay. So whether it was a clinical question also, if this was mentioned, it is a classical case of option B, chromoblastomycosis. What is this? Sclerotic bodies are seen. Sclerotic bodies also in NEET PG, as I've already told you. मैं जब PYQ discuss कर रहा था, Vikas sir would have mentioned it multiple times. मैं जब PYQ discuss कर रहा था, I've also told you कि ये NEET PG का question था recently. So copper penny bodies, what is they gave us? So copper penny bodies, sometimes they mention sclerotic bodies, sometimes they mention medlar bodies. So all of these are one and the same thing. So copper penny, medlar or sclerotic bodies are a feature of a fungal infection known as chromoblastomycosis. ठीक है? Whereas sporotrichosis के बारे में बताया था मैंने. In sporotrichosis we will get asteroid bodies, star shaped bodies मिलेगी. Asteroid bodies are usually seen. ये हमने PYQ में discuss कर चुके हैं chromoblastomycosis वाला question, right? So I hope most of you have not marked it wrong. Moving further, guys, to the next question. A 60-year-old male. So you would be thinking कि मैं बस PYQ, मैं बस questions to discuss कर रहा हूँ, because at this point it is important कि तुम्हें answers पता चले. Okay, all the things that you have marked or not, I have only given you the logic behind the answer and the correct answer, because now you don't wish to waste your time. I know I can totally relate to it कि मुझे अभी पूरा का पूरा भाषण या topic नहीं सुनना है. I need to know the answer and the logic behind it. ठीक है? So that is why I'm not going into great details of each and every option. ठीक है? No issues with that. Anybody? If you have having any doubt, please give any comments in the chat box, or you can message me personally on my Telegram handle. No issues with that. Please remember. Question number 35. A 60-year-old male presented to OPD with unilateral hearing loss and mild recurrent epistaxis. So, जब हम mild recurrent epistaxis and unilateral hearing loss सोचते हैं, so the first thing that comes to everybody's mind is juvenile nasopharyngeal angiofibroma. But here they have given it is a 60-year-old male. So definitely JNA can be ruled out, because juvenile nasopharyngeal angiofibroma, though it presents with unilateral conductive hearing loss and recurrent epistaxis, yaad rakhna, it is not common in elderly patient. Here it is a adult or an elderly patient along with other features like headache, difficulty in swallowing. Okay. On that is dysphagia. On examination, patient has palpable cervical lymph node. Nothing better than this. ये मैंने ENT में discuss कर चुका हूँ. Palpable cervical lymph nodes or cervical lymphadenopathy is the most common feature or the most common presenting feature of nothing but option A, option B, nasopharyngeal carcinoma. याद रखना, it is option B, nasopharyngeal carcinoma. As I've always told you, features दोनों के same होंगे, nasopharyngeal angiofibroma whereas carcinoma. But याद रखना, usually in angiofibroma, it would be a young adolescent male who will present to you with features of recurrent epistaxis along with a mass in the nasopharynx. Maybe there is a cheek swelling, there is frog face deformity, all of these features. Whereas if it is a nasopharyngeal carcinoma, it is not a mass, it is nothing else. Hearing loss also comes later because when the mass grows in size so much that it will block the eustachian tube, then the patient will develop glue ear or serous otitis media, and then the patient will have a unilateral conductive hearing loss. Okay? Tab hoga in the later stages. Epistaxis B is not very much common, but the most common presenting feature or presenting complaint of nasopharyngeal carcinoma is usually I have discussed with you the image of a Chinese patient having some cervical lymphadenopathy over here. Okay, so that is what is a nasopharyngeal carcinoma. And last time there was a question on nasopharyngeal carcinoma, but triad, that is what is known as Trotter's triad. That also I discussed in the PYQ session. Okay, no issues with this, anybody? Moving further. Identify the X-ray given in the following image. ये भी हमने discuss कर लिया था in the last ENT session that I had done in the QRS. Okay, so I hope so all of you have marked it right now because as you can see, it is a occipitomental view. Okay, mentum से लिया गया है, so it is a occipitomental view. Okay, the head is almost upwards and the mouth is open. People have told me that the mouth was open, and it was not asked for which paranasal sinus this X-ray view is taken. Rather, it was only asked which X-ray view is given in the following image. So the X-ray view which is given in the following image, it is an occipitomental view with the mouth open. That is a classical picture of option D, Waters view. Okay. If it was the straight one, occipitofrontal view with only 15 degrees angle, then it would have been the Caldwell's view. Okay. No issues with that. Townes and Schiller's view are usually done for mastoid. Okay. They are done for X-ray mastoid usually. A diabetic patient present. So there were 3 questions on diabetes. Jitna mujhe recall mila hai. Please correct me if I'm wrong. A diabetic patient presents with pain in nose and black mass around the nose and cheek area. So nose mein ya nose ke aspas cheek area mein, if there is a black mass in a diabetic or an immunocompromised patient. Immunocompromised means the patient who is diabetic or the patient who is HIV positive or the patient who is on a long-term steroid therapy after COVID-19. Okay? So long-term steroid therapy after COVID-19 also leads to immunocompromised status, and all of that will definitely lead to a severe fungal infection. Black jahan bhi aata hai, that is option C, mucormycosis. So here the most likely diagnosis is definitely mucormycosis. Okay? So I hope this was the easiest one. Allergic fungal rhinosinusitis. Please remember, as I've discussed with you, कि allergic fungal rhinosinusitis में there can be black color sputum plugs. Sputum plugs होंगे, याद रखना. Black color mass नहीं होगा in the nose or cheek area. And along with that, definitely this was a PYQ question repeated, which we have discussed also. So I don't think so there would have been any issue coming to a conclusion for this one. A diabetic patient. So there was another one which was asking about treatment of mucormycosis. So a diabetic patient presents to OPD with blood-stained nasal discharge and progressive blackish nasal discoloration. Again, blackish nasal discoloration. Which of the following is the treatment option of choice? So here also the answer is mucormycosis, and the drug of choice is option B, amphotericin or liposomal amphotericin B, which is the drug of choice for severe fungal infections like mucormycosis. No issues with that. ये हमने discuss कर लिया था, हमने aspergillus तक discuss कर लिया था कि उसमें voriconazole देते हैं, all of that. Okay. No issues with this one. Azithromycin, it is antibiotic, so definitely not used in fungal infection. Ketoconazole is an azole derivative, definitely used for fungal infection, but for mild to moderate fungal infection and not for severe fungal infections like mucormycosis. Okay? No issues with this, anybody? Next one. A 62-year-old diabetic male with severe pain in the ear and granulation tissue with discharge in the external ear. ये classical case था जो मैंने ENT sessions में discuss कर रखा है. The last ENT session also I have discussed it. Anti-ENT में भी discuss कर रखा था. So 62-year-old diabetic male with severe pain in the ear and granulation tissue with discharge in the external ear. On examination, patient has drooping of the mouth towards one side. Drooping of mouth towards one side is suggestive of facial nerve palsy. Okay, it is suggestive of facial palsy. What is the likely diagnosis? So here, if it is a diabetic patient, हमने ये discuss कर रखा है, elderly diabetic patient with severe pain, granulation tissue, it is more likely to be a case of option C, malignant otitis externa, when there is granulation tissue along with some discharge in the external auditory canal or the external ear. Okay, no issues with this, anybody? So please remember, ASOM and CSOM can be ruled out easily because there would not be any granulation tissue in the external ear as such. Okay, na? यहाँ पे there was a question on ASOM, I feel so. The same question which has been asked in NEET PG this time. Most of the people confused it with myringitis bullosa. So the same question was repeated again in FMG also. Please give that recall as well. Okay. No issues with this, anybody? So here the answer is malignant otitis externa. As we have discussed, मैंने सब कुछ discuss कर रखा था. The most common cause is Pseudomonas aeruginosa. Okay, the most common cause is Pseudomonas aeruginosa for this condition, right? So याद रखना. Next, diffuse otitis externa. If you are confused, so please remember diffuse otitis externa is usually multiple furuncles usually in the external auditory canal. The most common cause is Staph aureus, Staphylococcus aureus for that. ठीक है, वहाँ पे कोई granulation tissue नहीं बनेगा. There would be a pus discharge in the external canal, not a blood stain discharge. There would not be very severe pain. Yes, pain तो होगा. चलो pain से अगर differentiate नहीं कर पाते हो तो granulation tissue is not seen with diffuse otitis externa. It is a feature of malignant otitis externa. ठीक है ना? And it is commonly associated with diabetic patients also, malignant one. So it was easier to diagnose. Question number 40. A young woman with history of progressive mild to moderate bilateral hearing loss, which was aggravated, that means increased during her pregnancy. On examination, the tympanic membrane was normal. Which surgery should be done to treat this patient? I hope this was the easiest question, which we have discussed already. A patient, a young woman, usually presenting with progressive mild to moderate bilateral hearing loss, and which increases or aggravates during pregnancy. This is a classical case of otosclerosis, right? And as we know, otosclerosis means we do an otoscopic examination, and on examination here, the tympanic membrane is normal. As I've discussed, 90% times the tympanic membrane would be normal. Only in 10% times the tympanic membrane can show you a change, which is what is known as the flamingo pink appearance. That is what is known as the flamingo pink appearance. जिसी को क्या बोलते हैं हम? We also call it as the Schwartz sign, right? We also call it as the Schwartz sign, and that is suggestive of early stages of otosclerosis. There, the treatment would be sodium fluoride. ये हमने question discuss किया था. But at the same time, I also told you, if the patient is having a normal tympanic membrane, that means the patient is usually in the later stages of otosclerosis, not in the early stages. And here the patient needs a surgery. And which surgery is to be performed? So here, the best option, stapedectomy bhi tha option mein, but removal of stapes is not the best option. The best option that we have is option C, tympanotomy plus stepedotomy. Okay, we'll open the stapes, we'll remove the affected part, and we'll place the stapes piston prosthesis. We will rather place a stapes piston prosthesis. Okay, so that is what is the best treatment option. Tympanotomy plus stepedotomy should be done. Tympanoplasty is not done. Usually it is a surgery of choice for unsafe CSM वगैरह. Okay, conservative management is not done. We need to treat the patient. Okay, so otosclerosis, all the things we have discussed already. ठीक है, paracusis villosi, when the patient hears better in noisy areas, or Schwartz sign that I've already discussed with you. ठीक है, or the Carhart's notch 2000 hertz dip in the audiogram, pure tone audiometry. All of these features I've discussed. Moving further, bone anchored hearing aid. Bone anchored hearing aid, also called as BAHA. Okay, so usually this bone anchored hearing aid is required in patients where you cannot place in the canal hearing aid. जो normal conventional in the canal hearing aid होता है ना, that cannot be placed. Over there you require a bone anchored hearing aid where it is fixed on the bone with the means of screw. Okay, that is what is a BAHA or bone anchored hearing aid. इसके भी discussion किया हुआ है हमने. So it is used in which of the following condition? So I'm not pretty sure about the options. Please correct me if the options were other way around. Option A says serous otitis media. No, serous otitis media or glue ear or secretory otitis media. Here the problem is actually in the middle ear and the patient is having a conductive hearing loss. So here you will only do a myringotomy. You will open the tympanic membrane. You will drain the serous fluid. Okay, so you will drain the discharge, and then you will place a middle ear ventilation tube. That is what is called as a grommet. Okay, so myringotomy plus grommet insertion is what is done in cases of serous otitis media. ठीक है ना, इसमें कोई जरूरत नहीं होती है for a hearing aid. The patient will get relief immediately. Acoustic neuroma, as I've always discussed, ये question बहुत बार repeat हो चुका है. Acoustic neuroma, usually here, if the patient is having a bilateral acoustic neuroma or a bilateral vestibular schwannoma, which is usually a feature seen in cases of neurofibromatosis type 2. Here, as the eighth nerve is damaged, because acoustic neuroma is the eighth nerve tumor. So as the eighth nerve is damaged, so cochlear implant surgery would not be useful, because for cochlear implant we require a normal eighth nerve. So here rather you need to use a auditory brainstem implant. So ये question पहले आ चुका था, इस बार उन्होंने बाहर का question पूछा. Okay, so these are some unusual questions जो NEET INR series से आते हैं. So that was fine. So here bone anchored hearing aid कब लगेगा? When you cannot use a normal in the canal hearing aid, and that is what is option C, congenital external auditory canal atresia. So if congenital EAC atresia was there in option, because if the pinna and the external auditory canal, so if please remember, if congenital EAC atresia along with anosia, these were the features. So अगर anosia है, congenital EAC atresia है, so you cannot place a normal conventional hearing aid. In this condition, you need to place a bone anchored hearing aid. इसके अलावा most of the people are also giving me कि नहीं सर EAC atresia नहीं था ऑप्शन में, rather it was sensory neural hearing loss. ठीक है, तो अगर sensory neural hearing loss अगर था ऑप्शन में, then that would have been your best answer. ठीक है, if congenital EAC atresia was not there and rather SNHL was there, then that would have been your best answer. Sensory neural hearing loss. It is not used in case of conductive hearing loss. याद रखना. Moving further, question number 42. A classical case, surgery, ENT, ऑफ्था हर जगह डिस्कस किया था, सब थक गए थे ये डिस्कस कर कर. A patient was hit. I'm not sure if these were two different questions. लोग मुझे बोल रहे हैं कि दो अलग अलग questions थे. Which wall was fractured and second was कि which type, what is your diagnosis? So please let me know अगर wall का भी question था. So a patient was hit by a cricket ball and he developed diplopia, that is double vision. As we know, diplopia or double vision is usually due to the inferior rectus palsy. ठीक है ना? And there is a periorbital swelling which is seen. The radiograph is given below. What is the diagnosis? So here you can see in the MRI image, here you can see there is a classical teardrop sign. When the soft tissues of the orbit are going inside or protruding inside the maxillary sinus. This is the classical teardrop sign that we have discussed. And teardrop sign is due to the fracture of the floor of orbit. And fracture of floor of orbit is classically called as the option A, blowout fracture. And as we know, blowout orbital fracture, here you will see a teardrop sign on MRI or any of the X-ray. The patient will have diplopia or double vision on looking down. It is usually due to the inferior rectus palsy or the infraorbital nerve is paralyzed. That will also lead to sensation loss in this area commonly. Okay? So these are the usual findings that you can see in orbital blowout fracture. If they ask you the question, as I told you, if it is the most common wall which is fractured in the orbit, as all of you are quite aware, the most common wall to be fractured in orbit is the floor, followed by the medial wall. Whereas, as we have discussed, the weakest wall in the orbit is the medial wall, but the most common to fracture is the floor. No issues with that. Tripod fracture भी हमने discuss किया था. It is the zygomatic bone fracture. ठीक है, it is what is called as tripod fracture because उसके 3 extensions होते हैं, right? Lafourtes fracture is usually upper face fracture. All the 3 Lafourtes fracture we have discussed. When the fracture line is beneath the nose. Second, when the fracture line is pyramidal from the bridge of the nose. And third, when it passes from the orbits. Okay, so that this is definitely not a Lafourtes fracture. Moving further, guys. Question number 43. A child was brought to the emergency room with complaints of respiratory distress and cough. Anteroposterior view of X-ray shows steeple sign. Steeple sign, as we know, the top of the church. That is what is the steeple sign. And the steeple sign is due to narrowing of the subglottis. Okay, due to subglottic narrowing, there would be a steeple sign. And which airway infection in children will lead to subglottic narrowing? As we know, subglottic narrowing is usually seen in cases of acute LTB. Acute LTB, that is laryngotracheobronchitis, also known as CROW. So here the diagnosis is acute LTB or CROW. When the most common site affected is subglottis, there is narrowing, and due to that, there would be steeple sign on the X-ray which is seen. The patient will present to you with dyspnea or respiratory distress, along with the barking cough which is there in the patient, and definitely a stridor. Okay, so biphasic stridor is seen usually at the level of subglottis. Okay? So what would be the next step in the management? So the next step in management, definitely, as we know, the most common cause of CROW is parainfluenza virus, type 1, type 2, and type 3. So definitely it is a viral infection, but बहुत सारे लोगों को लगा कि viral infection है तो antibiotics नहीं देंगे. Please remember, I have clearly mentioned in my ENT test and discussion last time, this time, okay, classroom में भी, YouTube पे भी, everywhere, that though CROW is a viral infection, you need to give antibiotics to prevent any secondary bacterial infection. The patient is at a high risk of acquiring any secondary bacterial infection in the hospital, and therefore when you admit the patient, you will start the patient on humidified oxygen. Along with that, you will give some bronchodilators, जिस पे question आया था. The bronchodilators usually given are epinephrine. So nebulization with epinephrine is given, along with antibiotics to prevent any secondary bacterial infection and steroid to reduce the edema. ठीक है, laryngeal edema कम करने के लिए या subglottic edema कम करने के लिए we will give the steroids to the patient. No issues with this anybody? I hope this all of you have marked right. ठीक है, so this is the best option. मैंने बोला था अगर कुछ नहीं पता चलता तो जो सबसे बड़ा ऑप्शन दिखता है कभी कभी वो सही भी निकलता है. ठीक है. A 7-year-old child comes to OPD with complaints of snoring, mouth breathing and hearing loss. His grades have been falling in school. ये classical question हमने discuss कर लिया था. His scholastic performance is deteriorating या फिर his grades have been constantly falling in school. The teacher complains of that he is unattentive in class. So all of this is a classical feature. And when the child is asked, the child complains that he is not able to hear properly what the teacher says. That means the child is having hearing loss. And when you see there is a peculiar faces that I have discussed, the child usually opens his mouth for breathing. That means these are usually mouth breathers. The child snores a lot. This is classically due to adenoid hypertrophy. This is the classical picture of adenoid hypertrophy. As we know, adenoid usually grows in size till 6 years of age group. But if they grow in size beyond a normal point, therefore they will block the eustachian tube opening. As we know, adenoids are usually in the posterior nasopharynx. But if they grow beyond a point, okay, beyond a normal point, then they will block the eustachian tube opening. That will cause glue ear in the patient or serous or secretory otitis media. That will lead to a unilateral conductive hearing loss in the patient, right? The classical tha. So here it is a PYQ question. Recall, as we have discussed also this one. So snoring, mouth breathing, hearing loss are all features suggestive of adenoid hypertrophy to an extent where it has caused glue ear or serous or secretory otitis media. What is the next line of management? So the next line or the best line of management is definitely perform removal of adenoid, that is adenoidectomy, along with a myringotomy, and then insert of grommet, that is the middle ear ventilation tube. So as I've told you, तुमने बहुत लोगों ने गलती भी करी थी. ENT जब test and discussion first कर रहे थे हम, at that time we had multiple ENT test and discussions. ठीक है. So जो first class test लिया था हमने, there I have given option कि adenoidectomy, second was grommet, myringotomy plus grommet insertion, third was adenoidectomy with grommet insertion. So I told you myringotomy with grommet insertion से better answer होगा adenoidectomy with grommet insertion. Why? Though myringotomy is not mentioned, myringotomy तो करना ही है, okay? Default करना ही पड़ेगा अगर तुम्हें grommet insert करना. So myringotomy is opening in the tympanic membrane, that has to be done अगर grommet insertion करना है. But important thing is adenoidectomy should be mentioned in the question because the child is having adenoid hypertrophy and adenoid feces, which has been discussed. Okay, so that was a repeat question. No issues with this, anybody? Moving further, Koppe's nodules are seen, and I hope this is easy. Koppe's, and the second one that we discussed was the Busaka's nodules. So Koppe's nodules or Busaka's nodules are usually seen in iris, and both of these are features of uveitis. Both of these are features of classical anterior uveitis, to be specific. Okay, both of these are features of anterior uveitis. As I told you, we discussed about uveitis multiple times. Anterior uveitis can be either iritis, inflammation of the iris, or inflammation of iris plus the pars plicator, that is iridocyclitis. Okay, so in both these conditions, there can be some nodules which can appear on the iris. Those are known as Koppe's nodules or Busaka's nodules. B for Busaka, and Shivani ma'am, and I have reiterated the fact that Busaka's, B for Busaka, B for base of iris. So Busaka's nodules are usually found at the base of iris, whereas Koppe's nodules are found on the iris at the pupillary margins. They are found at the pupillary margins on the iris. No issues with this, anybody? So this we have discussed. Apart from that, definitely I discussed about keratic precipitates in anterior uveitis, which will form an arch configuration or an arch triangle. Okay? So that was easy. No issues with that. And usually the keratic precipitates are seen in the cornea, but nodules are seen on iris. Okay? Moving further, a child from low socioeconomic status presents with white foamy spots in both the eyes. What is the cause? So now some people are saying, sir, vitamin deficiency पूछी गई थी. Some people are saying, sir, deficiency नहीं था option में. There were different diagnoses which were given. So कुछ भी हो, ये सबको पता है. ये मैंने बार-बार PSM, PDA, almost everywhere I discussed it. ठीक है? So a child from the low socioeconomic status presents with white, foamy, toothpaste-like spots. These are nothing but your Bitot spots. And as we know, Bitot spots are seen due to vitamin A deficiency. And vitamin A deficiency leads to a condition known as option A, xerophthalmia. It leads to conjunctival xerosis or xerophthalmia. Okay? So any of these options related, vitamin A deficiency, conjunctival xerosis, xerophthalmia would have been the best answer for white dot spots. As we have discussed, according to WHO, it is X1B stage, and white dot spots are the most pathognomic feature of xerophthalmia. ठीक है, ये मैंने बोला था, नीट पीजी का भी क्वेश्चन है, PYQ में भी डिस्कस हुआ था ये अपना. ठीक है. So no issues with this, anybody? Moving further, a patient presents with floaters and flashes along with curtain-like shadow in front of the eye. What could be the diagnosis? So floaters and flashes, that is the only complaint that the patient is having, and then the curtain-like shadow in front of the eye. Usually the classical case here. So floaters and flashes along with curtain-like shadow is the feature of option B, retinal detachment, usually due to a rhegmatogenous, which is the most common. The most common RD, retinal detachment, is rhegmatogenous retinal detachment. Over there, the patient will have a curtain-like shadow, okay? Because there would be ballooning of the retina. Retina एक जगह से निकल जाएगा और आगे आ जाएगा. So ballooning of the retina would be there, and that leads to a curtain-like shadow in front of the eye, along with floaters and flashes. ठीक है? So याद रखना. So because wherever the retina has been detached, over there the patient will have a vision loss, and that will appear like a curtain in front of the eye. ठीक है? So that is what is the classical case of retinal detachment. I hope so. Retinoblastoma पर भी एक question था. Please give me that recall. What was the question exactly on retinoblastoma? Question number 48 says a child is being considered for intraocular lens implantation, IOL implantation, following a cataract surgery. So maybe the child had some congenital cataract and he was operated for the same, and now intraocular lenses are to be implanted in the child. What shall be kept in mind while choosing the power of the intraocular lens? So I hope this was very easy. As we have discussed, the normal adult eye is usually immetropic. ये हमने discuss किया था हफ्ता start करने से पहले. The normal adult eye is immetropic. Neither it is myopic, neither it is nor it is hypermetropic. ठीक है? Whereas the newborn eye हमने बात करी थी, newborn eye usually it is 16.5 mm. Okay, so axial length of adult eye is 24 mm, but axial length of newborn eye is 16.5 mm. That means it is shorter. As it is shorter, or is it smaller, therefore the newborn eye would be hypermetropic. Okay, newborn eye would be hypermetropic, and it is hypermetropic by +2 to +3 diopters. It is hypermetropic by +2 to +3 diopters. So अगर hypermetropic है तो क्या होगा आगे जाके? Myopic होगा ना. So there would be a myopic shift which would be seen in the patient. ठीक है? So at birth, usually the newborn eye would be hypermetropic by +2 to +3 diopters, and as the age progresses, usually the patient will have a myopic shift which is seen. Usually the eye will try to become immetropic now, and this is what is called as a myopic shift. ठीक है ना? So myopic shift is there. Therefore, usually till 2 years of age, अगर lens लगानी है तुम्हें, till 2 years of age usually 80% of the actual power is used. Okay, so till 2 years of age, 80% of the actual power is used. Till 2 to 8 years of age, 90% of the actual power of lens is used, and beyond that, adult size, whatever is the 100% power of actual lens, it is used. Okay, no issues with this. So that is what you need to remember. Moving further, question number 49. A 5-year-old boy presents with itching and redness in the eyes, along with ropey discharge, which is more in summer. What is the most probable diagnosis? Classical case, कोई confusion ही नहीं था. A young boy, as I told you, presenting with itching usually, which is the most common symptom, along with redness. Sometimes they will mention watering also, but here they mentioned a thick ropey discharge. That is what is your Maxwell-Lyon sign, right? Maxwell-Lyon sign. So this is a classical case which usually the symptoms increasing in summer. So as we know, this is a classical case of vernal keratoconjunctivitis, VKC, which is a type 1 hypersensitivity or an allergic conjunctivitis. And conjunctivitis, there would be redness, discharge, or watering only. Okay, that I've already discussed. So here definitely it is option B, spring catra, which is the another name for VKC, vernal keratoconjunctivitis. Though it is more in summer, as we know, spring catra is a misnomer. Okay, it is more in summer or warm weather, not in spring. But spring catra is the name, another name for VKC. That was your answer. GPC, giant papillary conjunctivitis, we have discussed about it. Here the papilla would be more than 1 mm in size. Bade papilla honge. An important thing over here, the patient will have a history of some contact lens use, or maybe the patient will have some history of some mechanical damage to the eyeball. Okay, that is what is a GPC. And तुम्हें ही confusion था, तो मैंने बोला था उस time कि VKC अगर आएगा, that would be a young boy with itching, with other features, okay, of conjunctivitis. So that was the case. Okay, and I've given you the mnemonic. I hope that worked for you. Omkar has the PSM video. So this was the mnemonic that we applied. VDO goes for VKC, M goes for thick ropey discharge known as Maxwell-Leon sign, S goes for the shield ulcer, P goes for cobblestone papillae, HASD goes for the Horner-Tranta spots on the upper limbus, and Omkar goes for the drug of choice for VKC, that is olaparib. No issues with that. And trachoma, as we know, it can be ruled out because trachoma is a follicular conjunctivitis, not a papillary conjunctivitis. Over there, the patient will more likely over there the patient will not have a thick ropey discharge. Okay, yaad rakhna, that is not a characteristic feature of trachoma. Yaad rakhna, important thing. And itching and redness are less predominant usually in cases of trachoma. Okay. Question number 50. A patient presents with bilateral ptosis which is variable during the day and progresses more in the evening. So this is the classical case. कोई गुंजाइश ही नहीं थी यहाँ गलती करने की. Patient with bilateral ptosis or drooping of eyelids, which is variable and it usually increases or progresses during the evening. That means worsening of symptoms during the evening or diurnal variations of the symptoms. This is the classical case. The most likely diagnosis here would be option B, myasthenia gravis. One more question was, I feel so, on the type of hypersensitivity of myasthenia gravis. As we know, myasthenia gravis is an autoimmune condition. So antibodies are formed, and as antibodies are formed, so it is due to presence of preformed antibodies. So it is a cytotoxic or a antibody mediated hypersensitivity. That is what is a type 2 hypersensitivity. But as I told you, अगर type 2 option में है and better type 5 option में है, so you need to mark type 5 as the best answer. मैंने बोला था कि for, please remember, for usually myasthenia gravis हो गया, Woodpasture syndrome हो गया. Over here I mentioned you, if type 5 is there in option, be specific and mark type 5. It is a subtype of type 2, but the best answer or the most specific answer would be type 5 hypersensitivity. अगर type 5 था आंसर में, well and good. If it was not there, then type 2 would have been your answer. ठीक है? No issues with this. Moving further. External ophthalmoplegia. Here also the patient will have palsy of muscles. There can be ptosis also. But yaad rakhna, it would not be it will not be showing diurnal variation. It is a classical feature of myasthenia gravis only. Horner syndrome, we know there is a partial ptosis, as we know, and it also does not show any diurnal variation or worsening in the evening. That is not a feature. Oculomotor nerve palsy may be, there would be a constant drooping or constant ptosis which is seen, not a diurnal variation again. Moving further, guys, talking about the next one. A patient sustained an injury, the hair bulb and the nerves are crushed at the base of the wound. Which is the likely one? So ये तो मैंने discuss कर लिया था. Dr. Vikas would have discussed in his sessions. I have discussed it in surgery sessions. QRS में discuss किया था. So as I've classically mentioned, all the wound images, okay? Hair bulb and nerves, if they are crushed at the base of the wound, this is nothing but option C, lacerated wound. This is a lacerated one. Whereas if the hair bulbs and nerves are cut at the base of the wound, then definitely it would be a incised wound with a sharp weapon. Okay? So here it is a lacerated wound, usually due to some trauma or road traffic accidents, वगैरह. So lacerated wound is the important thing. Hair bulb and nerves are crushed with irregular margins would be there. Whereas inside wound, there would be sharp margins with hair bulb and nerves which will be cut at the base. Stab wound will have the tearing which is seen, okay, and it is usually done with sharp weapons which are heavy sharp weapons के साथ किया जाता है. Contusion is due to rupture of the arterioles, okay, usually it is a bruise, nothing else. Moving further, question number 52. A patient was found to have an empty scrotum. So on investigation, left testis was found to be in the inguinal pouch. What is the diagnosis? ये तो classical case हमने PYQ में भी discuss किया, surgery में भी repeated multiple times. So if a patient is having an empty scrotum and the left testis is found in the inguinal pouch, so usually we know the testis usually develops in the abdominal cavity, but before birth, usually or during usually at birth, these testes will descend down from the inguinal canal into the scrotal sacs. But if they do not descend down into the scrotal sac, then they can get arrested somewhere, okay? And they usually get arrested at the inguinal canal or the inguinal pouch. So here also the left testis is arrested at the inguinal pouch, and this is the classical case of option A, undescended testis, also known as cryptorchidism. So ये दो options से मुझे कुछ लोग बोल रहे हैं, but I don't think so it would be possible. So it would be either undescended testis or cryptorchidism. That would be the best answer over here. If the testis would have been, जो हमने discuss किया था August का recall, if the testis would have been in the pelvic cavity or if it had been in the perineal fossa or anywhere else, then it would have been an ectopic testis. But as it is in the normal pathway में बीच में अटक गई है, therefore it is an undescended testis or a cryptorchidism. ठीक है, याद रखना. अपने नॉर्मल पाथवे से बाहर अगर है देन डेफिनेटली इट वुड बी एक्टोपिक टेस्टिस. ठीक है, टेस्टिस से और एक दो क्वेश्चन होंगे शायद. प्लीज लेट मी नो इफ दे वर. A male patient was having heaviness in scrotum and on examination bag of worm feel in the left testis was felt. What is your diagnosis? So I hope this was easy one. This we have discussed. Bag of worm feel लोगों ने बोला कि classically it was mentioned in the question. So if bag of worm feel was classically mentioned, it is due to dilated abnormally dilated tortuous pampiniform plexus of veins of the testis. And when there is abnormal dilated tortuous pampiniform plexus of the veins, it feels like a bag of worm. This is nothing but option B, varicocele. कुछ लोग बोल रहे इमेज भी दी थी, so image दी थी तो it would have been सोने पे सुहागा or it would have been a piece of cake for you. So this is a classical case of varicocele. No issues with this, anybody? Please remember this. Whereas indirect inguinal hernia, it would be only a swelling, no bag of worm feel वगैरह would be there. Hydrocele, here there would be only a fluctuant swelling which is there due to accumulation of fluid. Okay, there is no bag of worm feel as such. And अगर image आई थी, then definitely a bead-like or a bag of worm-like appearance would be seen over there. That would be a classical thing. Identify the given condition. So I hope this was the easiest one. So here you can see the placenta usually is lying in the lower segment. Normally it lies in the upper segment. But if it is a low-lying placenta, that is what is called as placenta previa. It can be grade 1 when it is dipping into the lower segment. It can be grade 2 when it is at the os of the lower segment or at the cervical os. If it is partially covering the internal cervical os, it is grade 3. And if it is completely covering the internal cervical os, it is grade 4. That is what is seen over here. People said me it is a grade 4 placenta previa, but they did not ask you which grade it was. Rather, it was only asked what is the diagnosis of the condition. So here the answer would be option B, placenta previa. Placenta accretae, as we know, here there would be absence of the nita bush layer which is there. Okay, the placenta would be in its normal place only in the upper segment or maybe dipping into the lower segment, but there would be absence of the nita bush layer, or the placenta would be invading the endo or myometrium or even till the serosa also. That is what is placenta accreta. Here the placenta is not invading any layer, so definitely it is not accreta. Vasa previa is when the vessels usually present in the os, cervical os. Okay? If any other options were there, please let me know. Moving further, guys. Question number 55. What is the first level of contact between the people and medical healthcare? So in India, as we have discussed about the levels of healthcare, I have given you the image, वो arrow वाली image बनाई थी मैंने PSM में. So that was the one. So first level of contact between people and medical healthcare. As I told you always, कि definitely तुम बस इतना याद रखते हो. Primary level is PSC, secondary level is the CHC, tertiary level is a district hospital or a medical college. ठीक है? But as I've always told you, please remember, PSC के पहले भी sub center आता है. Okay, beneath PSC also we have sub center. So अगर sub center is there in the option, that is the first level of contact between the people and medical healthcare. So please mark it as sub center as the first level of contact. उसके बाद आता है PSC. ठीक है? Please remember. Moving further, which among the following vaccine is given at birth? I'm not sure if there were 3 vaccines which were given. Some people are only going me recall कि hepatitis B का था. Some people are saying कि नहीं तीनों vaccines पूछे थे. So whatever it was, we have discussed it in great details in PSM, all the vaccination schedule this time. ठीक है? So I don't think so there was any issue. As I've told you, Bob is given at birth, right? Bob is given at birth. ये mnemonic था. So B first of all goes for the BCG vaccine, O goes for OPV का 0 dose, and B goes for hepatitis B का birth dose. Okay, so if 3 options were asked, then this is the answer. BCG, OPV 0 dose, and hepatitis B ka birth dose usually. Whereas if one vaccine was asked among all these, then hepatitis B is the vaccine which is given immediately at birth. ठीक है, याद रखना. So this is given intramuscular, this is given intradermal on the left deltoid, this is given intramuscular on anterolateral thigh, and this is given oral. ठीक है. HIV is usually not given at birth. It is started at 6 weeks along with the other pentavalent vaccines, that is DPT, hepatitis B, and HIV. Okay. So HIV started at 6 weeks. DPT is also started at 6 weeks. MR vaccine, the first dose is given at 9 months. Or it is given at 9 months. Okay? Moving further. Question number 57. Handedness of the baby develops by which age? So whether the baby is right-handed or left-handed, definitely handedness can be acquired as early as 18 months. But usually, normally the handedness develops completely the patient. You can tell the baby is either right-handed or left-handed for sure, by surety, by 3 years of age. Okay? So the best answer would have been 3 years. By 3 years of age, handedness develops properly in a child. Okay? Na? Yaad rakhna. 3 years के बाकी क्या क्या थे? The child is able to draw a circle by 3 years of age, that you need to remember, right? The child is able to make a tower of 9 cubes at 3 years of age. That is what is important, right? So at 4 years of age, the child is able to make a square. That is important. At 5 years of age, the child is able to make a triangle. So these are the important things that have been asked earlier also. Okay? Moving further, guys, most common type of seizures in second year of life. So most common type of seizures in children they have asked you, and ये मैंने बहुत बार discuss किया था in pedia, in medicine, in pharma, everywhere I've discussed this multiple times in neurology session. So most common type of seizures in children usually, or most common type of seizures in second year of life is usually the option B, febrile seizures. Due to a viral or bacterial infection, the child will have a high grade fever, and that can land up in febrile seizures. The drug of choice भी हमने discuss किया था, it is benzodiazepines. The drug is diazepam. In episodes, it is given either IV or rectally, whereas in between episodes, it will be given orally usually. No issues with that. Anybody? Subtle seizures, as we know, subtle seizures are the most common type of seizures in neonates or newborns. Here, the drug of choice is phenobarbital. ये भी discuss किया था in the first month of life. ठीक है? Focal seizures and absence seizures. So focal seizures can occur at any age group. There is no specific age group as such. Absence seizures, please remember, it occurs more commonly in children, but it is not the most common type of seizures. ये मैंने तुम्हें बार-बार correct किया है. Subtle seizures are more common in neonates, and absence seizures are not the most common type of seizures in children. Absence होती है, but it is not the most common type. Please remember, most common type is definitely the febrile seizures which are there. Now, last two questions. What is the surgical treatment option of choice for septate uterus? So this was the answer. So this was the question. What is done for septate uterus? As we have discussed, if the patient is only having recurrent pregnancy loss, then we need to go for a treatment option in cases of septate uterus or a bicornuate uterus. If it is a septate uterus, the better answer would be option A, hysteroscopic resection of the septum. If there is a septum in between the uterus, this septum is to be resected with the help of hysteroscopy. Okay, you will go from the natural orifice of the vagina. From there, you will go into the uterus with a camera, and along with a laser or a cautery, you can just resect this. You can ablate or resect this septum. Okay, that is what is a hysteroscopic resection. Laparoscopic resection करोगे क्योंकि ऊपर से तो जाना नहीं है. We need to go inside the uterus. So better is hysteroscopic resection. Laparoscopic resection is not done. Strassman's metroplasty is a unification surgery for bicornuate uterus, not for septate uterus. ठीक है? Last question today. A farmer while working in the farm was bitten by a snake. So some people are saying कि snake की image भी दी हुई थी. I'm not sure if the image was given. He presents with ptosis and muscle weakness. So if the patient is having drooping of the eyelids, that is ptosis, along with muscle weakness, usually the patient is more likely suffering, or sometimes the patient can also give you respiratory distress. So the patient is more likely suffering from a neurotoxic snake poisoning. Okay, the patient is suffering from a neurotoxic snake poisoning, और ये हमने image भी discuss की थी. Okay, we have discussed this in PYQ also. The patient is suffering from neurotoxic snake poisoning, and that is the Elapidae family, either a king cobra, common cobra, or a crate usually, right? And these are neurotoxic snakes, and these neurotoxic snakes will lead to muscle weakness. There would be diaphragmatic paralysis leading to respiratory distress and death of the patient. There can be ptosis in the patient. So this is more likely to be a case of neurotoxicity. And what is the most specific line of management? If they would have asked you what is the first line of management, answer would have been anti-snake venom. Okay, the first line in every snake poisoning is anti-snake venom. Followed by that, definitely we give neostigmine plus atropine. So option A is the best choice over here. It is neostigmine and atropine, which is the best choice over here. Okay, neostigmine and atropine, which is the best choice over here. Okay, no issues with this, anybody? So please remember, atropine is usually given to overcome any muscarinic side effects of neostigmine. Okay, that is the reason why we give atropine to the patient. Otherwise, neostigmine is the drug of choice for cobra bite, as all of you are quite aware, and we have discussed it multiple times. Physostigmine is used for atropine poisoning or datura belladonna datura poisoning. Okay, pyridostigmine is the drug of choice for myasthenia gravis. Thank you so much. It was great to have you all over here. I hope all of you have marked most of the questions right. Don't be discouraged. Okay, wait for the results. All the very best and good luck for the results from Team FMG. And I'll come up with subsequent recall sessions also. So till then, goodbye, good luck. Thank you so much.